What is going on, wonderful people? Welcome to today's Explainer. I am absolutely thrilled you're here because, well, we are going to tackle a really massive topic today. I want you to imagine we're standing right in front of a giant blank whiteboard, and I've got a fresh pack of incredibly bright neon markers. Today, we're setting a rapid-fire pace to completely master the pathophysiology and pharmacology of hyperlipidemia. I know, it sounds like a heavy subject, but trust me, once you understand these pathways, you are going to cruise through this material like a sharp knife through warm butter. Okay, you ready? Let's dive right in. So first off, what is literally the most dangerous thing about a quiet bloodstream? Think about it. It's the fact that you don't feel a thing, zero symptoms. While you're just going about your day, your quiet bloodstream might be slowly, silently hardening with cholesterol plaques. And this insidious, hidden process, it leads directly to atherosclerotic cardiovascular disease, or ASCVD. It is literally the leading cause of death worldwide. But hey, fear not, because today we are learning exactly how to fight back. All right, here's our game plan for today. 1. The ASCVD threat. 2. Disease classifications. 3. The drug arsenal. 4. Side effects and warnings. And finally, number 5, the treatment algorithm.
Let's jump into section 1, the ASCVD threat.
Okay, visualize drawing a beautiful, clean, wide-open artery on our whiteboard. That is what a normal lipid profile looks like, nice and smooth. Now, let's draw what happens during atherosclerosis. It is this slow, complex, really nasty process where plaques of cholesterol just deposit right into the arterial wall. Over time, this leads to a dangerous hardening and narrowing of your arteries. And you want to know what's really terrifying? It's when an area of this plaque suddenly ruptures. Boom. That rupture initiates a massive clotting cascade. This is exactly what causes typical angina, that sudden, severe, crushing chest pain that hits when these lipid plaques restrict blood flow and choke off oxygen to the heart muscle.
So the absolutely crucial point here is understanding exactly what hyperlipidemia is. Fundamentally, it's a medical condition characterized by elevated levels of triglycerides, total cholesterol, VLDL, or the really famous bad guy, LDL. And to make matters worse, it's usually paired with reduced levels of the good stuff, HDL. This precise imbalance is what accelerates that deadly plaque buildup we just talked about. And look, whether this is driven by genetics, a total lack of exercise, a diet consisting entirely of double cheeseburgers, or maybe a combination of all of the above, it is the primary driver of cardiovascular mortality.
Moving right along to section 2, classification of lipid diseases. All right, grab your mental neon markers because you need to visualize writing this cable out. Let's get a rhythm going. Type I is hyperchylomicronemia, think massive chylomicrons. Type 2A is familial hypercholesterolemia. Your LDL receptors are totally defective, so your LDL just skyrockets. Type 2B is combined. You are overproducing, so both VLDL and LDL are high. Then we have type 3, dysbeta-lipoproteinemia. Mutant ApoE leads to high IDL. Type 4 is hypertriglyceridemia, way too much VLDL production. And finally, type 5 is mixed, high VLDL and chylomicrons. Seriously, take a mental snapshot. Lock this picture in your brain right now.
All right, section 3, anti-hyperlipidemic drug classes. Time to bring out the big guns.
We are starting with the absolute rock stars of the pharmacy, the statins, technically known as HMG-CoA reductase inhibitors. These drugs, they cut through cholesterol synthesis like a hot knife through butter. Their main job is to lower LDL cholesterol by completely depleting the intracellular supply of cholesterol. By doing this, they actually force your cells to increase the number of LDL receptors on their surface. And if you're looking for the absolute most potent weapons in this specific class, you are reaching for Rosuvastatin and Atorvastatin. Think of it like this. Imagine a little factory inside the cell that just churns out cholesterol all day. Statins walk in, flip the switch, and shut down the main assembly line. That is the HMG-CoA reductase enzyme. So, because the cell suddenly can't make its own cholesterol anymore, it starts getting desperate. It literally throws more LDL receptors up on its outer cell membrane, which effectively acts like a vacuum, pulling all that bad LDL straight out of your blood so the cell can use it. It's such an incredibly elegant mechanism, right? Next up on the roster, we have the fibrates. We're talking drugs like gemfibrozil and fenofibrate. Now, these guys act as genetic switches. They activate PPRs, which are basically nuclear transcription factors. Fibrates are your absolute go-to for massive, and I mean massive, triglyceride reductions. We are talking about dropping those numbers by 20 to 50%. That makes them absolutely perfect for type 3 and type 4 hyperlipidemias. Oh, and as a nice little bonus, they also give your good cholesterol, HDL, a nice little bump up. Now, let's compare those with niacin and bile acid sequestrants. You want to think of these two by their completely different mechanisms of action. Niacin basically starves the liver of raw materials. It strongly inhibits lipolysis in your fat tissue. That means fewer free fatty acids actually make it to the liver, which means the liver can't produce as much VLDL. Pretty smart, right? On the other hand, sequestrants, like cholestyramine, act totally differently, right in the gut. They bind onto bile acids so they get pooped out instead of being recycled. This essentially tricks your liver into burning up its own cholesterol stores just to manufacture brand new bile.
And finally, we get to our newest, absolute most powerful tools, the PCSK9 inhibitors, like alirocumab and evolocumab. These heavy hitters are actually injectable antibodies that literally stop the PCSK9 enzyme from destroying your hard-working LDL receptors. These drugs are absolute game changers for patients with familial hypercholesterolemia. We are talking about dropping LDL by an unbelievable 50 to 70%, and that's on top of whatever statins are doing. And hey, let's not forget Ezetimibe, which has a super simple job. It just blocks you from absorbing cholesterol from your diet in the very first place.
Okay, Section 4, Side Effects and Contraindications. Time for this serious stuff.
Your liver and your skeletal muscles will not thank you. Listen up, because while statins are absolutely out there saving millions of hearts every single day, they are definitely not without their risks. They can cause myopathy, which is muscle pain, and in severe cases, something called rhabdomyolysis, which is a massive, highly dangerous breakdown of muscle tissue. They can also cause liver toxicity, and you've got to watch out because this is especially dangerous at super high doses or in patients whose kidneys just aren't clearing the drugs properly. Look, every drug class comes with its own signature side effect. Statins give you myalgia and liver tox. Niacin, it is famous for causing an intense, incredibly uncomfortable, bright red cutaneous flush. Honestly, patients hate it. Fibrates can cause gallstones and muscle issues. And those bile acid sequestrants, well, they basically just stay in your gut, so they will absolutely give you terrible GI distress, bloating, and constipation. You've always got to weigh the risks before writing that script.
Let me make this incredibly clear. Do not mix gemfibrozil with statins. Seriously, I will personally smack your gluteus maximus if you combine these two. Why? Because if you do, the risk of severe muscle breakdown, that rhabdomyolysis we talked about, absolutely skyrockets. It goes through the roof. This right here is a classic vital clinical pearl. Just avoid this combination completely. And that brings us to Section 5, the treatment algorithm. So how do we actually use these drugs? Let's march through the 4 strict statin benefit groups step by step. If a patient falls into one of these 4 buckets, you initiate statin therapy. Step 1, they already have clinical ASCVD. Easy choice, start the drug. Step 2, their primary LDL cholesterol is sky high, specifically greater than or equal to 190 milligrams per deciliter. Step 3, they are a diabetic patient aged 40 to 75. And step 4, maybe they don't have diabetes, but their estimated 10-year ASCVD risk is greater than or equal to 7.5%. These 4 scenarios are your absolute thresholds to trigger the deployment of your primary weapon.
But remember, folks, pills are not magic. You must always enforce lifestyle and diet modifications first. Yes, patients still need to put down the double cheeseburgers and get on a treadmill. But okay, say you max out their statins and their LDL targets still fail. Well, that's when you add ezetimibe or you break out those ultra-powerful PCSK9 inhibitors. And hey, if their triglycerides are just terrifyingly high, like we're talking over 500, you can actually add omega-3 fatty acids, specifically prescription icosapent ethyl, to force those numbers back down to earth.
So there you have it. You now possess the pharmacological arsenal to prevent the world's leading cause of death. The real question is, how will you deploy it? I challenge you right here and right now to review these pathways. Memorize that classification table like it's written in bright neon on the back of your eyelids. Master the side effects, and go conquer your exams and your future clinical rotations. Study hard, review the material, and I will see you in the next explainer.